Welcome to Last Minute Lecture. This free chapter overview is designed to help students review and understand key concepts. These summaries supplement, not replace, the original textbook and may not be redistributed or resold. For complete coverage, always consult the official text. If a seemingly healthy, 55-year-old guy walks into your clinic, shuts the door, and nervously mentions he's having trouble maintaining an erection, your first thought actually shouldn't be about his sex life at all.
Right, yeah, you should be thinking about his heart.
Exactly. Because biologically, that complaint carries the exact same risk for a future cardiovascular event as if he had just, lit up a cigarette right there in your exam room.
It's terrifying when you really think about it.
It totally is. And welcome to the deep dive. We are talking directly to you, the college student, staring down this just massive mountain of primary care content for the very first time. So consider this your personalized one-on-one tutoring session.
Today, we're cracking open primary care, interprofessional collaborative practice, the 6th edition, to really get into evaluating and managing genitourinary disorders.
Which is such a profound area of medicine. I mean, the genitourinary system is basically the ultimate biological whistleblower.
Oh, absolutely. The kidneys, the bladder, ureters, the prostate, the vasculature, they are all just incredibly sensitive barometers for systemic disease.
Right. And I think a lot of students look at the GU system and think, okay, well, it's a plumbing issue. We have pipes, a pump, a filter. It's mechanical.
Yeah, they oversimplify it.
Totally. But the reality of primary care is that a single symptom here, like a tiny drop of blood in the urine or localized pain, can either be a completely benign nuisance or just a massive 5-alarm systemic fire.
And solving those mysteries requires a true team. I mean, you can't operate in a silo here.
Right.
You're going to need physical therapy, urology, nephrology, oncology, pharmacology, all of them talking to each other, which is the fundamental framework of collaborative practice.
Yeah, because knowing the pathophysiology only gets you halfway there.
Exactly. Knowing who to call, when to refer, and how to manage the patient collaboratively is what actually makes you a successful clinician. So we're going to teach this content in the exact order it builds upon itself in your text.
We're going to decode those dense algorithms, unpack the tables, and really translate the care models into accessible language.
Right, focusing on how interprofessional practice shapes real-world clinical decisions.
So grab your notes, get comfortable, and let's just get into it. We're starting with the visible symptoms that bring patients into the clinic. And there is perhaps no symptom more common, yet more tragically underreported than incontinence.
That's a huge issue.
It really is.
Yeah.
To set the stage for the sheer scale of this, the financial burden of incontinence in the U.S. is staggering. We are looking at nearly $66 billion annually.
Wow.
$66 billion. And a massive portion of that is funding nursing home placements because families simply can't manage the care at home.
Well, the epidemiology is just striking. I mean, it affects 30 to 50% of older women and 17% of older men.
Which is a massive chunk of the population.
It is. Up to half of all elderly nursing home residents experience it. But here is the data point that often catches students off guard. Like 20 to 30% of young community dwellers are also affected.
Wait, young people? Really?
Yeah. It's a massive issue across multiple demographics. It's not just an elderly issue.
Okay, I want to push back on a pervasive myth here then, because it's one that patients bring into the clinic constantly. I hear people say, look, I'm getting older, my hair is graying, I've got wrinkles, and my bladder leaks a little when I laugh. It's just gravity and time, it's normal.
Right, it's just aging excuse.
Yeah, and I suspect some providers even dismiss it under that same logic.
Right.
But functionally, if the muscular and neurological pathways are intact, age alone shouldn't cause the system to fail.
The text is incredibly rigid on this point. Urinary incontinence is never considered a normal or expected outcome of aging. Never. At any age. It is always a symptom of an underlying condition. Now, aging brings comorbidities, right? Like impaired mobility, pelvic floor weakness, weight gain, or diseases like asthma that cause chronic coughing, or even heart disease requiring diuretics. Those are the contributors. But the aging process itself does not dictate incontinence.
That's a huge distinction.
It is. But despite how treatable it is, patients are profoundly embarrassed. So the primary care provider has to be a detective. You have to actively screen for it because they will not volunteer the information.
Okay, so let's look at the pathophysiology. The text categorizes incontinence into 5 main types, and we really need to understand the structural mechanics of each to treat them. Let's start with stress incontinence.
Okay.
My understanding is this is purely a pressure differential issue. Like the pressure outside the bladder suddenly exceeds the resistance of the sphincter.
That captures the physics perfectly. Stress urinary incontinence, or SUI, is the leakage of urine when intra-abdominal pressure spikes.
So coughing, sneezing, laughing.
Heavy lifting, exactly. That abdominal pressure transmits down to the bladder. Now, the text divides this into two specific anatomical failures. First is anatomic SUI, which is characterized by hypermobility of the bladder neck.
Meaning the structural hammock holding it up has just given way?
Yes. Normally, the pelvic floor muscles support the bladder neck so it sits high up in the pelvis. When you cough, the abdominal pressure compresses the urethra against that firm muscular floor, which helps pinch it shut.
Right.
But if the pelvic floor is weak, the bladder neck drops down. It becomes hypermobile. Now, when you cough, the pressure just pushes the urine straight out.
Ah, I see. And what's the second failure?
The second is intrinsic sphincter deficiency, or ISD. Here, the bladder neck is just sitting open at rest.
Just wide open.
Basically, yeah. The internal sphincter itself has lost its tone, often from prior pelvic surgeries or trauma. In ISD, even the slightest movement, like a tiny pressure increase, causes a leak.
Man, that sounds awful.
Yeah.
Okay, next is urge incontinence, which I know is often grouped under the umbrella of overactive bladder, or OAB. This isn't a mechanical leak from a cough. This is a sudden neurological or muscular misfire where the patient gets this completely uncontrollable sensation that they have to void immediately.
The mechanism here is a rise in detrusor pressure. So the detrusor is the primary smooth muscle making up the bladder wall. During the filling phase, the detrusor is supposed to stay completely relaxed.
It's just supposed to hold the fluid.
Exactly. But in urge incontinence, you have detrusor overactivity. The muscle begins violently spasming or contracting against the patient's will.
And what causes that?
It can be idiopathic, like we don't know the exact origin, but we know it involves the muscarinic M2 and M3 receptors misfiring in the bladder tissue. Or it can be neurogenic.
The neurogenic meaning the communication line between the brain and the bladder has been severed or damaged.
Right.
Like you see this in spinal cord injuries or multiple sclerosis or advanced diabetes where autonomic neuropathy has destroyed the signaling. The brain says hold it, but the message just never reaches the detrusor.
Exactly. And another cause of urge is poor bladder compliance. The bladder wall is supposed to be elastic, stretching like a balloon to accommodate volume without increasing internal pressure.
Right, it expands.
But if chronic inflammation or radiation therapy turns that elastic tissue into stiff scar tissue, the bladder loses compliance. Even 50 milliliters of urine will cause a massive, sudden spike in pressure, forcing the urine out.
Wow. Okay, then we have mixed incontinence, which is just a brutal combination of both stress and urge. You leak when you sneeze due to structural weakness, but you also suffer from those sudden detrusor spasms.
It's double the trouble.
Yeah. And the fourth type is overflow incontinence, which seems fundamentally different to me because the bladder muscle isn't overactive, it's underactive or blocked.
Right. Overflow is a passive loss of urine. The tank never empties completely. It just fills and fills and fills until the internal hydrostatic pressure finally overcomes the urethral resistance.
And then it just spills over.
Yeah. Small amounts of urine just passively dribble out. This happens either because there's a physical roadblock, like an enlarged prostate clamping down on the urethra, or because the detrusor muscle is exhausted and just too weak to mount a contraction to empty the tank.
Which brings us to the fifth type. And this one is so vital for primary care because it's often entirely reversible. Functional or transient incontinence.
This is a huge one to catch.
Yeah. This is when the actual urinary plumbing, the detrusor, the sphincter, the urethra is working perfectly, but something outside the GU system is causing the leak. The text gives us box 127.2, the diapers mnemonic. Let's break down the underlying mechanisms here.
Sure. The diapers mnemonic is an essential clinical tool. D stands for delirium or confusional state. If the brain's cortical inhibition is compromised by delirium, the patient just loses the higher level cognitive ability to suppress the micturition reflex.
Makes total sense. And the I.
I is for infection, specifically a symptomatic urinary tract infection. The bacteria cause intense mucosal inflammation,
Which irritates the stretch receptors, right?
Exactly, tricking them into triggering detrusor contractions even at really low volumes.
Okay, A is for atrophic urethritis or vaginitis. I know as women enter menopause and estrogen levels plummet, the mucosal lining of the urethra and vagina thins out It loses elasticity and becomes highly friable.
Right. And without that plump, estrogen-fed tissue to help create a seal, the urethra just can't maintain closure pressure.
P is for pharmaceuticals, which we'll dive into heavily in a minute. The second P is for psychological factors like severe depression, where the patient simply loses the motivation or executive function to reach the toilet, though that's pretty rare.
E stands for excess urine output. So if a patient has uncontrolled diabetes, the excess glucose in their blood spills into the urine.
And glucose is an osmotic diuretic, right?
Exactly. It drags massive amounts of water with it, filling the bladder faster than the patient can manage. You also see this in congestive heart failure when patients take heavy loop diuretics.
Right. Then R is for restricted mobility. If severe arthritis, or like a hip fracture, means it takes the patient 10 minutes to walk down the hall, the bladder might simply reach its maximum physiological capacity before they get there.
Yeah, it's a functional barrier. And finally, S is for stool impaction.
Stool impaction is so fascinating to me from a physics standpoint. The rectum sits directly behind the bladder. So if the rectum is packed with hardened stool, it physically pushes forward against the bladder wall.
It does. It decreases the bladder's physical capacity and irritates the shared pelvic nerves, which causes spasms.
So as a provider, before you start prescribing medications or referring for surgery, you must run through that diapers list. I mean, if you clear the impaction or treat the UTI or adjust the diuretic timing, the incontinence often just resolves completely.
Exactly. It's the low-hanging fruit.
But assuming we've ruled out the transient causes, how do we actually figure out which of the primary types, stress, urge, or overflow we're dealing with in the clinic? Like, how do we translate this pathophysiology into a physical assessment?
It begins with a hyper-detailed voiding diary. You need to know the exact volume, timing, and triggers of every leak over a 3-day period.
Okay, diary. What about the physical exam?
Well, the physical exam is where the clinical reasoning crystallizes. For women complaining of stress leakage, you're assessing that urethral mobility we discussed. The text highlights the Q-tip test.
Oh, right. I can visualize this. You take a sterile Q-tip, lubricate it, and insert it superficially into the urethra.
Yep.
If the pelvic floor is structurally sound, the Q-tip should stay relatively horizontal, even under pressure.
But if you ask the patient to strain or bear down, simulating a cough, and that Q-tip swings upward, moving more than 30 degrees from the horizontal plane, it proves the bladder neck has dropped down into the pelvis.
Wow, just a simple visual cue.
Yeah, it visually confirms hypermobility of the bladder neck, pointing directly to anatomic stress incontinence. And then you follow that with a simple stress test.
Which is just having them cough.
Right. Have the patient cough while lying supine. If nothing happens, have them stand up and cough again, utilizing gravity to test the sphincter's integrity.
Simple but effective. And what about diagnosing overflow incontinence? If the patient is just dribbling, how do we know if it's an overactive spasm or a full tank spilling over?
You check a post-void residual, or PVR. You instruct the patient to go to the bathroom and empty their bladder as completely as possible.
And then what?
Then you use a bedside bladder ultrasound scanner or insert a straight catheter to measure what's left behind. A healthy bladder empties almost completely. Like a normal PVR is less than 50 milliliters.
And an abnormal one.
If the PVR is over 100 milliliters, that is highly abnormal. The tank is not emptying, confirming overflow incontinence.
Okay, we have our diagnosis. Let's look at box 127.3, the management of incontinence. This is where interprofessional collaboration truly shines, because we don't jump straight to surgery or heavy medications.
Never. We always start with non-pharmacologic behavioral therapy.
I think of this like trying to reprogram a glitchy neurological thermostat. You have to intentionally retrain the brain-bladder connection.
Exactly. For stress and urge incontinence, the first tier of management is timed voiding. You instruct the patient to go to the bathroom strictly every 2 hours by the clock, whether they feel the urge or not.
Just to keep the volume low.
Exactly. Keep the bladder volume artificially low so the detrusor never gets stretched enough to trigger a spasm. We also utilize double voiding.
Which is, what, going twice?
Yeah, instructing the patient to void, stand up, wait a minute, and then sit back down to try again, just to ensure the bladder is completely empty.
But if we're dealing with stress incontinence, that structural weakness, the absolute cornerstone of treatment is pelvic floor muscle training, commonly known as Kegel exercises.
Right.
And here's where our physical therapy colleagues become just indispensable.
The text explicitly notes that patients often perform Kegels incorrectly. If you just hand them a pamphlet, they usually end up flexing their abdominal muscles, their glutes, or their thighs.
Which does nothing.
Worse than nothing, it can actually increase intra-abdominal pressure, worsening the leak. So a referral to a specialized pelvic floor physical therapist is a game changer.
The PT is like the mechanic for the pelvic floor. They don't just tell the patient to squeeze, they use biofeedback, placing sensors on the perineum so the patient can look at a monitor and visually see when they're activating the correct muscle group.
It's amazing technology.
Yeah, and they use vaginal weights, starting around 20 grams, which the patient have to actively grip with their pelvic floor muscles while walking around. They can even use electrical stimulation, like a specialized 10NS unit, to artificially contract the muscles and show the brain what the correct activation feels like.
It is intensive rehabilitation. The protocol requires 3 sets of 10 contractions, held for 5 seconds each, performed 3 times a day for up to 6 months before achieving maximum benefit.
6 months. So primary care diagnoses the deficit, but the physical therapist really coaches the patient through the grueling process of rebuilding that structural hammock. But what if structural rehab isn't enough? Or what if we're dealing with severe urge incontinence where the detrusor is just firing out of control? We move to pharmacology, and we have to be incredibly precise here because the drugs target completely different mechanisms depending on the type of incontinence.
Very true. For urge incontinence, our pharmacological goal is to paralyze or at least heavily sedate that overactive detrusor muscle. The detrusor contracts when acetylcholine binds to the muscarinic receptors.
Okay, so we block them.
Right, so we deploy anticholinergic or antimuscarinic agents like oxybutynin or tolterodine. These drugs blockade the M2 and M3 receptors in the bladder wall, preventing the acetylcholine from binding, which dramatically reduces the spasming.
Conversely, if we're dealing with stress incontinence, we don't want to relax the bladder. We want to tighten the sphincter. And the internal sphincter is controlled by alpha-adrenergic receptors. So we use alpha-adrenergic agonists like pseudoephedrine to stimulate those receptors and increase the closure pressure of the urethra. Or, if the issue is atrophic vaginitis, we prescribe topical vaginal estrogen to plump up the mucosal lining and improve the tissue seal.
And for overflow incontinence, the pharmacology depends on the roadblock. If the prostate is clamping down on the urethra, we want to relax the smooth muscle of the outflow tract using alpha-1 blockers.
Or physically shrink the prostate, right?
Yes, using 5 alpha-reductase inhibitors to shrink the glandular tissue.
I really want to pause and heavily underline a massive warning label attached to those urge incontinence medications, the anticholinergics.
Oh, this is critical.
We are talking about prescribing these to an older demographic to stop bladder spasms, but the anticholinergic mechanism isn't isolated to the bladder.
It's a classic example of why primary care must look at the whole system. Anticholinergics cross the blood-brain barrier. Acetylcholine is a primary neurotransmitter for memory, learning, and cognitive processing in the central nervous system.
So when you prescribe oral oxybutynin to an 80-year-old frail patient, you are systematically blocking their acetylcholine in their brain.
The systemic side effects are miserable, profound dry mouth, severe constipation because you've paralyzed the gut motility, blurred vision. But the cognitive cascade is the real danger.
Right. The text explicitly warns that these drugs contribute directly to cognitive decline, confusion, and overt delirium in the elderly.
You must conduct a thorough baseline cognitive assessment before starting antimuscarinics in a geriatric patient, and monitor them rigorously. You are constantly weighing the benefit of a dry pad against the risk of dementia-like symptoms.
Sometimes curing the incontinence simply isn't worth inducing profound confusion.
No, it's really not.
This just highlights how treating a localized symptom requires a systemic lens. Now, we touched on the fact that overflow incontinence in men is frequently caused by a physical roadblock. By far, the most common roadblock is the prostate gland.
The infamous donut.
Exactly. The prostate sits directly beneath the bladder, wrapping entirely around the urethra like a donut. If that donut swells, the hole in the middle shrinks, choking off the urine flow. Let's tackle the malignant reason that donut might grow first: prostate cancer and the highly debated screening guidelines.
Prostate cancer screening has undergone massive philosophical shifts over the last 2 decades. The text anchors its recommendations on the American Urological Association, or AUA, guidelines.
And the primary tool is the PSA blood test, right? Prostate-specific antigen.
Yes. PSA is a protein produced exclusively by the prostate gland. When the prostate is inflamed, enlarged, or cancerous, it leaks excess PSA into the bloodstream.
So a high PSA means prostate trouble. Now, I can hear a student applying a very logical, straightforward line of reasoning right now. They're thinking, cancer is bad, Catching cancer early is good. Therefore, we should check a PSA on every single man every year, starting at age 40. Isn't more data always better?
It's a brilliant question because it forces us to grapple with the concept of overdiagnosis and the cascade of clinical harm.
Walk us through that.
Prostate cancer is uniquely heterogeneous. Yes, some prostate cancers are aggressive and lethal, but a massive percentage of prostate cancers are incredibly slow-growing, indolent tumors. If you aggressively screen every 45-year-old, you will undoubtedly find microscopic cancers.
But are they dangerous?
That's the thing. Those specific cancers might take 40 years to grow large enough to cause a single symptom.
Meaning the patient would have eventually died of old age or a heart attack, completely unaware they even have prostate cancer.
Exactly. But once you hand a patient a piece of paper that says cancer, the psychological terror is profound. That elevated PSA triggers a cascade.
A workup cascade.
Right. First, a transrectal prostate biopsy, which carries a risk of severe sepsis. If the biopsy is positive, it often leads to a radical prostatectomy surgical removal of the gland. And the nerves controlling erections and the sphincter controlling urine run directly alongside the prostate.
So to cure a cancer that may never have harmed them, we subject the patient to a surgery that has a high probability of leaving them permanently impotent and incontinent.
We've ruined their quality of life to treat a purely statistical threat.
That is wild, which is why the AUA guidelines designate the crucial screening window as men aged 55 to 69. And even in this group, screening isn't automatic.
It mandates shared decision-making.
Right. The primary care provider must sit down, explain the mechanics of overdiagnosis, outline the risks of false positives, and let the patient's personal values dictate the path.
Exactly. If a 60-year-old patient values the absolute highest chance of avoiding cancer death, regardless of the side effects, you screen. If he prioritizes preserving sexual and urinary function above all else, you might decline.
And the text notes that to further balance these harms, for men 55 to 69 who do opt into screening, a 2-year interval is now preferred over annual screening.
It still catches significant, fast-growing diseases, but drastically reduces the background noise of false positives.
Makes sense. For men over 70, or anyone with less than a 10 to 15-year life expectancy, routine screening is generally not recommended, since the slow-growing nature of the disease means they'll almost certainly outlive the cancer.
But regardless of age, if a patient presents with advanced symptomatic prostate cancer, the primary care provider must be vigilant for the systemic red flags.
Like metastasis.
Right. Prostate cancer loves to metastasize to the bone, specifically the vertebral column. If a patient with known prostate cancer suddenly complains of acute lower extremity weakness, numbness in their legs, sudden urinary retention, or sudden fecal incontinence...
You don't pick them for an MRI next week.
No, you call the emergency department and send them immediately. Those symptoms indicate the metastatic tumor mass in the spine has grown large enough to cause acute spinal cord compression. The expanding tumor is physically crushing the spinal nerves.
Time is cord. If that pressure isn't relieved emergently, usually with high-dose corticosteroids and emergent neurosurgery or radiation, the nerve death becomes permanent and the patient will be paralyzed.
It's an absolute emergency.
Okay, moving from the malignant roadblock to the benign one, let's look at benign prostatic hyperplasia, or BPH. This is a non-cancerous proliferation of the glandular and stromal tissue of the prostate, and it is incredibly prevalent.
The text describes it as ubiquitous. As men age under the influence of dihydrotestosterone, the prostate simply grows. Up to 80% of men over age 70 have histological evidence of BPH.
80%.
Yeah. As it expands, it compresses the prostatic urethra, leading to classic lower urinary tract symptoms, or LUTS.
How do we systematically quantify how much this is impacting the patient's life? Because some men have massive prostates and pee fine, while others have minor enlargement and can't empty at all.
The primary care tool is the AUA Symptom Index. It's a standardized 7-question survey. It asks the patient to rate, on a scale of 0 to 5, how often over the past month they've experienced a sensation of incomplete emptying, frequency of urination, intermittency, which is stopping and starting of the stream urgency, a weak stream, straining to begin urination, and nocturia, which is waking up at night to void.
And then you tally that up.
Right, you tally the score to classify their symptoms as mild, moderate, or severe. This score, far more than the physical size of the prostate, dictates your treatment algorithm.
And speaking of physical size, we have to talk about the physical exam, the digital rectal exam, or DRE. The anterior wall of the rectum rests directly against the posterior aspect of the prostate. So when you insert a gloved, lubricated finger into the rectum, what distinct tactile differences are you feeling to separate BPH from cancer?
Well, with BPH, the hyperplasia is generally uniform. The prostate will feel symmetrically enlarged. The texture is classically described as rubbery and smooth, similar to the tip of your nose or the eminence of your thumb.
And it shouldn't hurt, right?
Right, it's generally non-tender. However, if your finger encounters a discrete hard nodule, or if the gland feels starkly asymmetrical, or if the entire surface has an indurated, stony, woody texture, that is highly suspicious for a malignant tumor.
And that finding changes everything.
That physical finding alone warrants an immediate, expedited referral to urology for a biopsy.
Let's explore a very common, highly dangerous system-level workflow failure regarding BPH.
Right.
Say a 65-year-old male patient with known moderate BPH has been managing fine for years. Suddenly, he presents to your clinic in agony. He hasn't been able to pass a drop of urine in 14 hours. He is in acute urinary retention. His bladder is distended up to his umbilicus. What's the very first thing you should be looking for when you pull up his medication list?
You immediately hunt for over-the-counter cold, flu, and allergy medications.
Because of the decongestants.
Exactly. When a patient gets the sniffles, they head to the pharmacy and buy a decongestant, like pseudoephedrine. Pseudoephedrine is a sympathomimetic. It stimulates the alpha-adrenergic receptors to constrict blood vessels in the nose, clearing the congestion.
But, as we discussed earlier, the internal urethral sphincter is also packed with those exact same alpha receptors.
Right, so the culmination travels systemically, hits the bladder neck, and tells that sphincter to clamp down tight.
Just locks it up.
Completely. And they also frequently buy allergy meds containing diphenhydramine Benadryl, which has potent anticholinergic properties. Remember, anticholinergics paralyze the detrusor muscle.
Oh, wow. So you have a patient whose prostate has already narrowed the urethra to a pinhole. They take a pill that simultaneously clamps the exit sphincter completely shut and paralyzes the pump mechanism.
The result is absolute acute urinary retention. It's a physiological trap, and primary care must educate every BPH patient to avoid these specific over-the-counter drugs.
Before we leave the prostate, we must cover inflammation of the gland, prostatitis. The text utilizes the National Institutes of Health, or NIH, classification system to separate this into 4 distinct pathophysiological categories.
The NIH categories define both the etiology and the acuity. Category A is acute bacterial prostatitis. This is a severe ascending systemic infection typically caused by E. coli. The bacteria invade the prostatic tissue, causing massive inflammation.
And how does that present?
The patient presents acutely ill, spiking fevers, chills, profound pelvic or perineal pain, and a prostate that is exquisitely tender, warm, and swollen on DRE.
And the text explicitly warns against vigorously massaging an acutely infected prostate during that DRE, right?
Yes, highly critical point. Vigorously palpating a Category I prostate can force the trapped infected fluid directly into the bloodstream, triggering instant life-threatening bacteremia and sepsis. You touch it gently to confirm, and then you stop.
Wow. Okay, what about Category 2?
Category 2 is chronic bacterial prostatitis. The bacteria are present, but the infection is smoldering. The symptoms are less severe, there's usually no fever, but the pelvic pain and urinary symptoms persist or recur for at least 3 months.
And it's hard to treat, right?
Incredibly difficult to eradicate because the prostate gland is a sanctuary site. Antibiotics have a hard time penetrating the tissue barrier.
Category 3 is chronic pelvic pain syndrome, or CPPS. I understand this is the most common and arguably the most frustrating type.
Extremely frustrating.
The patient has all the pain and misery of prostatitis, but when you culture their urine and prostatic fluid, it is completely sterile. There's no demonstrable bacterial infection, just chronic neurogenic inflammation.
Right. And finally, Category 4 is asymptomatic inflammatory prostatitis, which is usually discovered completely by accident. Say a urologist is doing a biopsy for an elevated PSA and happens to notice white blood cells in the tissue under the microscope.
So treating these categories really requires knowing the limits of your scope. As a primary care provider, when do you manage and when do you refer?
Primary care handles the straightforward Category I infections with oral antibiotics if the patient is stable and works through the initial stages of CPPS. But urology referral is absolutely indicated if a Category I patient is showing signs of systemic sepsis or urinary retention.
You don't mess around with that.
No. You also refer if the DRE suggests any nodularity, If the PSA remains abnormally high after treating an infection, or if the patient is suffering from recurrent refractory category 2 infections that might require a prolonged culture-specific antibiotic strategy or intervention for prostatic stones that are harboring the bacteria.
That transition from visible roadblocks to microscopic clues brings us to the silent detectives of the urinary tract: proteinuria and hematuria. We are looking at blood and protein in the urine, usually discovered incidentally on a routine low-cost urinalysis. The patient feels completely fine, but the dipstick is flashing bright red warnings.
The urinalysis is an incredibly powerful window into the systemic health of the patient. Let's start with proteinuria, utilizing the diagnostic algorithm from figure 130.1.
Okay, let's break that down.
The glomerulus is the microscopic filtration unit of the kidney. It's a highly specialized, high-pressure capillary tuft wrapped in a basement membrane and specialized cells called podocytes. This filtration barrier is designed to let small molecules like water, urea, and sodium pass through, but it specifically blocks large macromolecules like albumin and other proteins, keeping them in the blood.
So if we dip a urine sample and it lights up positive for protein, it means the delicate microscopic filtration barrier has been structurally breached. The holes in the filter are torn.
Exactly. But a dipstick is just a qualitative estimate. It tells you protein is present, but not how much. The algorithm demands that step 1 is quantifying the exact volume of the leak.
Right. And how do we do that?
You must order either a cumbersome 24-hour urine collection where the patient saves every drop of urine for a full day, or, much more conveniently, a spot urinary protein to creatinine ratio, the ACR, which calculates a highly accurate estimate from a single sample.
And the quantification dictates the severity. I know if that calculation shows the patient is dumping greater than 3.5 grams of protein into their urine per day, they've crossed a massive clinical threshold into what we call nephrotic syndrome.
Nephrotic syndrome is not a specific disease. It's a clinical state of extreme glomerular damage that triggers a massive multidisciplinary systemic diagnostic workup. You have to find out what pathogen, autoimmune complex, or metabolic process is actively destroying the kidneys.
And the algorithm directs primary care to cast a wide net here.
Very wide. You test for systemic lupus erythematosus, or SLE, using an ANA screen because lupus autoantibodies attack the glomerulus. You rule out viral etiologies by checking for hepatitis B, hepatitis C, and HIV, which can all cause viral nephropathies. You test for Goodpasture syndrome using anti-glomerular basement membrane antibodies. You evaluate for advanced diabetic nephropathy.
It's a sweeping investigation. But while we are running all those blood tests, we can't just let the kidneys continue to bleed protein, right? We have to manage the proteinuria to stop the active destruction. And this brings us to one of my favorite pharmacological mechanisms to explain: the use of ACE inhibitors, or angiotensin-converting enzyme inhibitors, and ARBs, angiotensin receptor blockers.
The pharmacological cornerstone of kidney protection.
Yeah, I explain this to patients like plumbing a high-pressure filter. Blood enters the glomerulus through the afferent arteriole, gets squeezed through the filter under high pressure, and exits through the efferent arteriole. When the filter is damaged, that normal high pressure just forces massive amounts of protein out through the torn holes, accelerating the damage.
Right.
ACEs and ARBs specifically target and dilate that exit pipe, the efferent arteriole. By widening the exit, you dramatically drop the internal hydrostatic pressure inside the filter. It's like installing a pressure relief valve.
That is the precise hemodynamic mechanism. They decrease the intraglomerular filtration pressure. Even if the holes in the filter are still damaged, lowering the pressure pushing against them drastically reduces the amount of protein forced out.
Which is the goal.
Our clinical goal is to get that total protein excretion rate down to 1 gram per day or less. Because, as we'll discuss shortly, heavy protein leakage isn't just a symptom. The protein molecules themselves are physically toxic to the downstream renal tubules. They cause scarring, driving the progression of chronic kidney disease.
Okay, let's turn to the other silent marker: hematuria. Figure 130.2 outlines the hematuria algorithm. Now, a patient might look at a urinalysis that shows microscopic blood and say, "Hey, doc, I don't feel any pain, there's no burning, I feel great, so a little blood isn't a big deal, right?
Right.
Better than if it hurt." As a primary care provider, how do we react to that logic?
With intense clinical suspicion.
Really? Even with no pain?
Especially with no pain. In the realm of the genitourinary tract, we view pain very differently. If there is blood in the urine and the patient is in agonizing flank pain, we're actually somewhat relieved because we know we're likely dealing with a passing kidney stone.
Right.
If there is blood and severe burning upon urination, we are looking at a symptomatic bacterial urinary tract infection. Painful hematuria usually has a very clear mechanical or infectious benign cause.
But if they're bleeding from their urinary tract and they feel absolutely nothing.
Painless hematuria is the absolute flashing red flag for urothelial malignancy. It is the hallmark presentation of bladder cancer, ureteral cancer, or renal cell carcinoma. Tumors are highly vascularized. They build their own fragile, chaotic blood vessel networks to feed their growth.
So it's just a tumor bleeding.
Right. As urine washes over the tumor, these fragile vessels shear off and bleed microscopic amounts of red blood cells into the urine completely silently.
Wow. The algorithm in the text is explicit on how to handle this. If a patient presents with painless hematuria, your first step is a urine culture to absolutely rule out a silent infection. If the culture is negative, they demand a full, aggressive cancer workup.
The workup is three-pronged. First, you order 3 separate urine samples for cytology. A pathologist will look at the cells shed into the urine under a microscope, hunting for malignant dysplastic cells.
Okay, cytology is one.
Second, you order a non-contrast CT scan of the abdomen and pelvis. This visualizes the upper urinary tract, the kidneys, and the ureters looking for solid masses. Third, and most crucially, you mandate an immediate referral to urology for a cystoscopy.
Which is where they use the camera.
Yes, the urologist inserts a camera up the urethra and visually inspects every millimeter of the bladder lining for tumors.
The interprofessional referral guidelines here are so clear. Transient hematuria in a young woman that is definitively linked to a UTI and resolves completely after a course of antibiotics can be managed entirely within primary care. But frank hematuria, meaning the urine is visibly red or brown, or any persistent painless microscopic hematuria, or hematuria accompanied by signs of urinary obstruction, bypasses primary care observation and goes straight to urology. You do not wait and watch painless bleeding.
Because if you wait and watch, and it is a tumor, you're allowing it time to invade the muscle wall of the bladder, drastically changing the survival prognosis.
This highlights a grim reality. If these issues we've discussed, severe obstruction from a prostate, massive proteinuria from a damaged filter, uncontrolled vascular pressure are not caught and managed, the end result is the total destruction of the kidney itself. That brings us to renal failure, the ticking clock of kidney function. Let's start with the acute side. Acute kidney injury, or AKI.
AKI is an abrupt, rapid decline in renal filtration function, and it is vital for students to grasp that AKI isn't a subjective clinical feeling. A patient doesn't just look like they have an AKI.
It's numbers-based.
Totally. It is defined by strict mathematical, physiological criteria established by the KDIGO guidelines, kidney disease. Improving global outcomes. Table 131.4 breaks down the diagnostic staging based on highly specific serum and volume metrics.
Walk us through the math that triggers an AKI diagnosis.
An AKI is officially defined as an absolute increase in serum creatinine of 0.3 milligrams per deciliter or more within a 48-hour window. Creatinine is a waste product of normal muscle breakdown that the kidneys constantly filter out. If the kidneys suddenly stop filtering, the creatinine backs up in the blood. A jump of just 0.3 is enough to confirm the filter has crashed.
Well, compared to their baseline, right?
Alternatively, it's defined as an increase in serum creatinine to 1.5 times the patient's known baseline over the prior 7 days.
And there's a volume metric as well, right?
Yes, the urine output criteria. If a patient's urine production drops below 0.5 milliliters per kilogram of body weight per hour for 6 consecutive hours, they have an AKI, regardless of what the blood work shows. It means the perfusion to the kidney has dropped so low that the filtration pressure has flatlined.
Man, if an AKI is not rapidly reversed, or if a patient suffers from decades of poorly controlled diabetes or hypertension, slowly destroying their nephrons, they develop chronic kidney disease, CKD. The text provides a phenomenal framework for visualizing a patient's long-term risk. Let's teach the listener how to interpret the KDIGO CKD grid from tables 131.2 and 131.3, which culminates in the risk heat map of figure 131.1.
The CKD grid is a 2-axis prognostic system. The vertical axis measures GFR, the glomerular filtration rate. This is a calculated number representing the overall filtering horsepower of the kidneys.
And how is that graded?
It ranges from G1, which is normal or high function, with a GFR of 90 or greater, scaling down through G2, G3A, G3B, G4, all the way down to G5, which is is a GFR of less than 15. G5 is end-stage renal disease. The kidneys have failed.
So the vertical axis is horsepower. What's the horizontal axis?
The horizontal axis is albuminuria, measuring the structural integrity of the filter by looking at how much protein is leaking into the urine. It is graded from A1, which is normal, to mildly increased at less than 30 milligrams per gram, to A2, which is moderately increased between 30 and 300, to A3, severely increased at over 300 milligrams per gram.
Okay, imagine this grid in your mind, where a patient's specific GFR intersects with their specific albuminuria level determines their overall risk for progressing to kidney failure and cardiovascular death. If we look at the heat map in figure 131.1, the top left corner high GFR, low protein leakage is colored green. The patient is safe.
Right.
As GFR drops and protein leakage increases, you move diagonally down and to the right, passing into the yellow zone, meaning moderate risk, then into the orange high risk zone until you hit the bottom right corner, which is deep red. Red is the danger zone. Catastrophic kidney failure is imminent.
The clinical revelation hidden in this grid is that GFR alone doesn't tell the whole story. A patient can have a relatively preserved GFR, say G2, mildly decreased function. But if their structural damage is severe and they're at an A3 level of massive proteinuria, they instantly jump across the chart into the orange or red high-risk zones.
This goes back to what we touched on earlier. Why is protein leakage so heavily weighted in this risk model?
Because the proximal tubules of the kidney, the delicate tubes that process the fluid after it leaves the glomerulus, are not designed to handle large protein macromolecules. When massive amounts of albumin are forced into the tubule, the tubular cells try to reabsorb them.
And that causes problems.
Huge problems. This unnatural reabsorption triggers a massive inflammatory cascade within the cells, releasing cytokines and fibrotic growth factors. The protein literally acts as a toxic irritant, causing the surrounding interstitial tissue to scar and turn fibrotic. The more protein they leak, the faster they destroy their remaining functioning nephrons.
Which brings us full circle to why primary care providers aggressively prescribe ACE inhibitors and ARBs.
Yeah.
We have to drop the pressure to stop the toxic protein cascade. From a purely interprofessional systemic management standpoint, what is the single most critical intervention a primary care provider can execute to slow a patient's slide toward that red zone?
Rigorous, non-negotiable blood pressure control. The consensus guidelines demand an absolute target of less than 130/80 for patients with CKD.
Because the pressure just wrecks the filter.
Hypertension is a mechanical wrecking ball to the microvasculature of the glomerulus. If you do not control the systemic blood pressure, the intrarenal pressure will remain high, the filter will continue to tear, and the kidney will die.
As the primary care provider managing this slow decline, at what exact point on that GFR axis do you pick up the phone and call the nephrologist?
The text mandates an interprofessional handoff to nephrology when a patient crosses into stage 4 CKD. That is a GFR severely decreased to a window between 15 and 29.
Why stage 4? Why not wait until stage 5 when the kidney actually fails?
Because preparing for kidney failure takes months. You refer at stage 4, so the nephrologist has adequate time to establish a relationship, discuss renal replacement therapy hemodialysis versus peritoneal dialysis, and initiate advanced care planning.
Oh, because of the physical access needed for dialysis.
Exactly. The vascular surgeon needs time to create an arteriovenous fistula in the patient's arm, and that fistula needs months to mature before it can withstand the pressure of a dialysis machine. If you wait until GFR is 10, the patient crashes into the ER in uremic shock, requiring emergency surgery and a high-risk central venous catheter. Proactive interprofessional referral at stage 4 saves lives.
That concept of shared vascular highways is the perfect pivot point, because the kidneys are entirely dependent on tiny, high-pressure blood vessels. Kidney disease and cardiovascular disease share almost all the same systemic risk factors: hypertension, diabetes, smoking, hyperlipidemia. If that endothelial highway is getting blocked with atherosclerotic plaque, we need an early warning system.
We do.
And that brings us back to the hook we opened the show with. We're looking at a condition that is often the very first clinical sign that the vascular highway is failing: erectile dysfunction, or ED.
It is a paramount topic for primary care, and one that is tragically suffocated by mutual silence in the exam room. The text highlights a double silence. Patients wait for the provider to ask about their sexual health because they are embarrassed or assume it's just a normal part of getting older.
And the providers?
Conversely, providers often wait for the patient to bring it up, either because they feel uncomfortable discussing sexual mechanics or because they are pressed for time and want to focus on serious medical issues like blood pressure.
And the tragic irony is that by skipping the question, they're missing the most serious medical clue of all. ED isn't just a quality of life complaint. It is a sentinel symptom.
It is the ultimate systemic barometer. Erection is fundamentally a hemodynamic event. It requires a massive, rapid influx of blood into the corpus cavernosum, mediated by nitric oxide signaling, causing endothelial relaxation. The penile arteries are very small, about 1 to 2 millimeters in diameter.
Smaller than the heart's arteries.
Much smaller. The coronary arteries feeding the heart are larger, around 3 to 4 millimeters.
I see where this is going. If systemic atherosclerosis plaque buildup is occurring throughout the patient's body, the smaller pipes are going to clog long before the bigger pipes do.
Exactly the mechanism. The endothelial dysfunction chokes off the penile arteries years before it severely narrows the coronary arteries. The text states this with terrifying clarity. Incident ED, meaning the very first time a man under the age of 60 reports any grade of erectile dysfunction, carries the exact same future cardiovascular risk as if that man were currently smoking cigarettes, or if he had a strong family history of a myocardial infarction.
Let that sink in for a moment. A 55-year-old man telling you his erections are getting weaker is the physiological equivalent of a blaring siren, warning you that a heart attack or stroke is in his near future.
Therefore, your clinical assessment, as outlined in box 132.1, must go far beyond the pelvis. Treating ED isn't just handing out a pill, it's a systemic audit. You review neurologic risk factors, like a history of stroke or undiagnosed multiple sclerosis, which can sever the autonomic nerve signals.
What else?
You hunt for endocrine disorders, specifically uncontrolled diabetes, which destroys both the microvasculature and the peripheral nerves, or hypogonadism, low testosterone.
And you execute a rigorous medication review. So many of the drugs we prescribe in primary care chemically induce ED. Beta blockers and thiazide diuretics used for blood pressure and SSRI antidepressants are notorious for blunting the erectile response.
Because the etiology is so complex, the treatment requires a truly multidisciplinary team. You might need cardiology to optimize vascular health and manage the atherosclerotic risk. You need primary care to tightly control the A1C. And you often need psychologists or sex therapists.
Because of the psychological aspect.
Right. The text emphasizes that organic, psychogenic, and relational factors usually overlap. If a man loses an erection once due to a minor vascular issue, the performance anxiety and psychological terror of it happening again can trigger a massive release of adrenaline during his next sexual encounter. Adrenaline is a potent vasoconstrictor. It actively fights the erection, creating a self-fulfilling cycle of failure. You have to treat the mind, the relationship, and the vessels simultaneously.
We've spent a lot of time on chronic vascular issues, but let's shift to a chapter where hesitation or a misdiagnosis can literally cost a patient an organ within hours. We are moving to testicular disorders, specifically the terrifying presentation of acute scrotal pain.
Separating a benign nuisance from a surgical emergency is the name of the game here.
Let's contrast the major players in the differential diagnosis outlined in Table 133.1.
The clinical presentation is your primary compass. Let's begin with the most critical emergency. Testicular torsion. Inside the scrotum, the testicle is suspended by the spermatic cord, which houses its arterial blood supply and venous drainage. In some men, a congenital anatomical variant called the bell-clapper deformity allows the testicle to swing freely inside the tunica vaginalis.
Meaning it's not anchored down, it can spin.
And if it spins, the spermatic cord twists like a wet towel. This initially cuts off the low-pressure venous outflow. Blood pumps into the testicle but can't escape, causing massive engorgement. As the pressure builds, it eventually chokes off the high-pressure arterial inflow. The testicle is now totally ischemic.
And what does that look like clinically?
The clinical presentation is dramatic and explosive, sudden onset of excruciating scrotal pain. On physical exam, because the cord is twisted and shortened, the affected testicle is often pulled high up into the scrotum and lies transversely or sideways. The pain triggers profound vagal nerve stimulation, resulting in severe nausea and vomiting.
What is the action required when you suspect torsion?
Immediate emergent urologic surgical consultation. Time is tissue. The golden window is 6 hours.
6 hours from onset.
Yes. If the urologist cannot untwist the cord and restore blood flow within that window, the testicular tissue undergoes irreversible ischemic necrosis. The organ dies and must be surgically removed.
Compare that explosive onset to epididymitis or orchitis.
Epididymitis and orchitis are inflammatory or infectious processes. The epididymis is the coiled tube sitting on the back of the testicle that stores sperm. If bacteria like chlamydia or gonorrhea in young men or E. coli in older men invade the tube, it swells.
So it's more gradual.
The presentation here is much more gradual. The pain builds over days, not minutes. Crucially, because it is an infection, it is highly likely to present with systemic inflammatory findings like a high fever, elevated white blood cell count, and urinary burning. On exam, the epididymis is indurated and tender, but the testicle maintains its normal, vertical, anatomically anchored position.
And then there is Fournier disease or Fournier gangrene, which is just the stuff of clinical nightmares.
It is a polymicrobial necrotizing fasciitis of the perineum and scrotum. A mix of aerobic and anaerobic bacteria invade a microabrasion in the skin. The bacteria produce toxins that cause rapid thrombosis blood clots in the subcutaneous blood vessels, starving the overlying skin and fascia of oxygen, causing it to rot and turn gangrenous.
And the size.
The presentation involves perineal redness, massive swelling, fever, lethargy, and a hallmark sign. Pain that seems completely out of proportion to the visible skin changes. The tissue is dying underneath.
You also might feel crepitus on the physical exam, right?
Yes. Crepitus is a crackling sensation under the skin, like crushing Rice Krispies, caused by the gas produced by the anaerobic bacteria trapped in the tissue planes. The action here is immediate, emergent surgical debridement, cutting away the dead tissue, and massive doses of broad-spectrum IV antibiotics. It is highly lethal, with mortality rates approaching 20 to 30% if missed or delayed.
So synthesizing all of this, what is the absolute golden rule for a student evaluating a patient with acute scrotal pain?
The golden rule is, when in doubt, get an ultrasound and err on the side of a urologic emergency. Specifically, a duplex Doppler ultrasound.
Because of the blood flow mapping.
Exactly. This technology uses sound waves to visualize the physical structure, but the Doppler function visually maps the blood flow in real time. If the Doppler shows absent or severely decreased arterial flow to one testicle, you have confirmed torsion. If the flow is massively increased and hyperemic, it points to inflammation like epididymitis. Never, ever send a patient home with sudden, severe testicular pain without a definitive objective diagnosis.
Now, testicular pain isn't always a problem with the testicle itself. Due to the complex shared nerve pathways of the genitourinary system, severe testicular pain can actually be referred, pain originating from higher up in the tract. This seamlessly brings us to urinary calculi, better known as kidney stones.
Kidney stones are infamous for the sheer agony they inflict. Managing them requires a deep understanding of fluid dynamics, ureteral anatomy, and smooth muscle pharmacology.
Let's start with the clinical presentation from box 134.1. The pain of a passing kidney stone called renal colic is legendary. The ureter is a narrow, muscular tube designed to softly peristalsis liquid urine from the kidney to the bladder. When a jagged, crystallized rock drops into that tube, the ureter violently spasms in an attempt to push the invader out.
It's an intense spasm.
This causes a sudden onset of excruciating colicky pain in the flank that radiates down into the lower abdomen, the groin, and yes, the testicle or labia.
The text makes a brilliant clinical distinction here regarding the nature of the pain. Intermittent waxing and waning pain suggests the stone is actively moving and tumbling down the ureter, meaning the obstruction is incomplete. Constant, unyielding, dull pain suggests the stone has lodged firmly in place, causing a complete obstruction and stretching the kidney capsule above it.
And they often have blood in the urine too, right?
Right. Hematuria is present in roughly 64% of cases because that jagged crystal physically lacerates the highly vascular mucosal lining of the ureter as it scrapes its way down.
But the primary care provider must be intensely vigilant for a specific red flag here. A patient with a known kidney stone who suddenly spikes a fever. Why is that combination so critical?
A stone accompanied by a fever signifies a closed-space, non-draining upper tract infection. The stone has completely corked the ureter, urine behind the stone becomes stagnant, and bacteria begin multiplying exponentially.
And it has nowhere to go.
Because the ureter is blocked, the infected purulent urine cannot drain down into the bladder. Instead, the pressure builds inside the kidney until that infected fluid is physically forced backward into the renal, venous, and lymphatic systems, dumping massive amounts of bacteria directly into the central circulation.
It is a recipe for instant fulminant sepsis.
It is a life-threatening urologic emergency. You do not wait for the stone to pass. It requires immediate surgical intervention to decompress the system, usually by a urologist placing a stent past the stone to let the pus drain, or a radiologist placing a percutaneous nephrostomy tube directly through the patient's back into the kidney.
Assuming there's no fever and the patient is stable, how do we diagnose and manage the stone?
The gold standard imaging modality is the non-contrast CT scan of the abdomen and pelvis. It provides a three-dimensional map of the GU tract. It visualizes the exact density of the stone, its precise location, and its exact millimeter dimensions. And when it comes to management, size is everything.
Let's break down the math from Table 134.2, the spontaneous stone passage rates. Because this table dictates your interprofessional workflow. If a stone measures 1 millimeter, the data shows it will pass spontaneously 87% of the time. The plumbing is wide enough.
So you just manage symptoms.
You prescribe strong NSAIDs for the inflammation, antiemetics for the nausea, tell them to drink massive amounts of water and give it time.
But if the CT scan shows a stone that is greater than 10 millimeters, the spontaneous passage rate plummets to 25%.
Just drops off a cliff.
The internal diameter of a normal ureter is only about 3 to 4 millimeters. A 10-millimeter stone is a massive mechanical mismatch. It is physically impossible for it to navigate the narrow anatomical choke points without assistance.
So for the stones in the middle, say a 5 to 9 millimeter stone, we don't just wait, but we also don't immediately cut. We use medical expulsive therapy, or MET, detailed in Figure 134.1. How does MET artificially change the physics of the ureter?
The distal portion of the ureter, the part closest to the bladder, is heavily populated with alpha-adrenergic receptors embedded in the smooth muscle. We prescribe alpha blockers, most commonly tamsulosin. By blocking these receptors, the medication paralyzes the smooth muscle of the lower ureter,
Giving the stone room to pass.
the tube relaxes, dilates, and stops spasming. This effectively widens the channel and reduces the resistance, significantly increasing the probability that the stone will simply drop into the bladder.
But if MET fails, or if the stone is massive, or if the patient's pain is totally refractory to medication, we execute the referral to urologic surgery. And the surgical technology here is fascinating.
It is highly advanced. They utilize shockwave lithotripsy, or SWL, which uses targeted acoustic sound waves generated outside the body to blast the stone into fine, passable sand. For stones trapped in the lower ureter, they perform ureteroscopy, or URS, passing a microscopic fiber optic camera up the urethra, through the bladder, and into the ureter to grab the stone with a tiny wire basket, or obliterate it with a holmium laser.
And for really big ones.
For massive, complex stones residing inside the kidney itself, they use percutaneous nephrolithotomy, going directly through the flank to extract the rock.
There's a specific clinical caveat in the text regarding pregnant women presenting with kidney stones, though.
Yes. Pregnancy naturally increases the risk of stone formation due to elevated progesterone causing ureteral dilation and urinary spaces. If a pregnant patient requires surgical intervention for a stone, ureteroscopy is the primary, safest modality. Shockwave lithotripsy involves acoustic energy and radiation from the targeting fluoroscopy, which is absolutely contraindicated as it could severely damage the developing fetus.
We also need to talk about the long-term interprofessional team member for stone formers, the dietitian. Once a patient forms one calcium oxalate stone, their risk of forming another is incredibly high. What is the evidence-based prevention strategy?
Stone prevention is an exercise in fluid dilution and balancing urine chemistry. The foundational rule is massive hydration. The patient must consume enough fluid to physically produce more than 2 liters of urine every single day, keeping the minerals too dilute to crystallize.
And diet.
The diet must be low in sodium because high sodium forces the kidneys to excrete more calcium into the urine. It should also be low in animal protein, which increases uric acid and lowers urine pH.
But there is a massive counterintuitive trap here that students constantly fall into. The stone is made of calcium. So the logical patient response is, I will stop eating dairy, I will restrict my calcium intake.
Which is the exact wrong thing to do.
Right.
The text explicitly states you must maintain a moderate dietary calcium intake. If you restrict dietary calcium, you actually increase the risk of oxalate stones. Here's the mechanism. Normally, dietary calcium binds with dietary oxalate in the gut, forming an insoluble complex that is harmlessly excreted in the stool.
So if you don't eat calcium.
If you remove calcium from the diet, all that free oxalate in the gut gets absorbed into the bloodstream, travels to the kidneys, and forms massive oxalate stones in the urine. You need the calcium in the gut to trap the oxalate.
It is a brilliant physiological pearl. Now, a jagged stone sitting in the urinary tract acts as a perfect, porous fortress for bacteria to hide in, shielding them from antibiotics and immune cells. This leads us perfectly into the realm of urinary infections and sexually transmitted diseases. Let's start with urinary tract infections. The text draws a very hard line, dividing UTIs into two categories: uncomplicated and complicated. Why is this distinction so crucial?
Because it completely dictates your antibiotic selection and duration. An uncomplicated UTI almost exclusively refers to a lower tract infection cystitis occurring in a healthy, premenopausal, non-pregnant female with completely normal genitourinary anatomy. The pathogen is highly predictable, usually a susceptible strain of E. coli, and a short 3-day course of narrow-spectrum antibiotics like nitrofurantoin works perfectly.
A complicated UTI is basically anything that falls outside of that narrow definition.
Correct. Any UTI in a male is automatically considered complicated because the bacteria had to travel up a 20-centimeter urethra and bypass the antimicrobial properties of prostatic fluid to get there, suggesting an anatomical anomaly or a more virulent pathogen.
What about other factors?
Any infection involving a structural abnormality like a kidney stone, an indwelling Foley catheter acting as a bacterial highway, a patient with immunosuppression, or a pregnant patient is complicated. These require urine cultures, longer courses of broad-spectrum antibiotics, and close monitoring for systemic spread.
Let's run through the anatomy and risk factors from boxes 135.1 and 135.2. Why are females vastly more susceptible to UTIs than males?
It is pure anatomical geography. The female urethra is exceptionally short, averaging only about 4 centimeters long compared to the male's 20 centimeters. Furthermore, the female urethral meatus is located in very close proximity to both the vagina and the rectum. This makes mechanical transfer and bacterial colonization from the perianal region into the bladder significantly easier.
What about the risk factors for women who suffer from recurrent UTIs?
Decreased fluid intake and irregular bladder emptying allow bacteria to multiply without being flushed out. But the biological environment of the vagina is critical. A healthy vagina is populated by lactobacillus, which produces lactic acid, keeping the vaginal pH low around 4.5.
And E. coli hates acid, right?
Exactly. This acidic environment is hostile to E. coli. However, as women enter menopause and estrogen drops, the lactobacillus dies off. The pH rises, and E. coli freely colonizes the vaginal vault, ready to invade the urethra.
Sexual intercourse is also a massive mechanical risk factor. The physical friction of coitus can literally massage perianal bacteria up that short 4-centimeter urethra into the bladder. This is why primary care providers advise patients prone to UTIs to void within 10 to 15 minutes after intercourse to mechanically flush the urethra.
That physical flush is key.
The text also notes that spermicide use is highly detrimental because the chemical destroys the protective lactobacillus, allowing the pathogenic bacteria to overgrow.
Shifting to the other half of this topic, sexually transmitted infections. The diagnostic process here, utilizing boxes 135.3 and 135.4, requires the provider to master the art of the sexual history and the comprehensive physical exam.
Taking a sexual history is an incredibly delicate skill. It requires an absolute lack of judgment, total professionalism, and high clinical suspicion. You can't just ask, are you sexually active? You have to know the specific mechanics.
Exactly. You must explicitly ask what kind of anatomical contact occurred, oral, vaginal, or anal, because the site of contact dictates the site of testing.
Right. If you don't ask, you don't test.
If a patient engaged in receptive oral sex, a standard urine PCR test will completely miss a raging pharyngeal gonorrhea infection in their throat. Your minimum physical exam must reflect this systemic reality. It is never just an anogenital exam.
So you check the mouth.
You must look inside the mouth for pharyngeal exudates. You must examine the skin, specifically the palms of the hands and the soles of the feet, for the classic macular rash of secondary syphilis. And you must systematically palpate the inguinal and femoral lymph nodes for painful adenopathy. STIs are systemic pathogens.
Let's look at the treatment guidelines in box 135.5 and table 135.1, focusing specifically on gonorrhea, which is a terrifying public health crisis right now.
Neisseria gonorrhea is a brilliant, highly adaptable pathogen. Over the past few decades, it has systematically mutated to develop resistance to almost every antibiotic arsenal we've thrown at it. It defeated the penicillins, it defeated the tetracyclines, and more recently, it has developed alarming resistance to fluoroquinolones like ciprofloxacin and oral cephalosporins like cefixin. We are running out of weapons.
Because of this widespread aggressive resistance, the CDC mandates a dual therapy approach to try and outsmart the pathogen's mutational pathways. What is the mandatory standard?
The current gold standard is a heavy, single intramuscular injection of ceftriaxone, which is a potent third-generation cephalosporin combined simultaneously with an oral dose of azithromycin.
Explain the pharmacological logic behind hitting it with two drugs at once.
You're attacking the bacteria from two completely different mechanical angles simultaneously. Ceftriaxone targets the bacterial cell wall, preventing it from building its structural defense. Azithromycin penetrates the cell and binds to the bacterial ribosome, completely shutting down its ability to synthesize proteins.
So you break down the wall and stop the factory.
Exactly. By destroying the wall and shutting down the internal machinery at the exact same time, you ensure the infection is utterly eradicated. And you drastically reduce the chance that a single surviving bacterium can mutate and develop resistance to both mechanisms simultaneously.
But there's a massive behavioral flaw in treating STIs. You can give the patient the perfect dual therapy, eradicate their infection, and send them home. But if they go home and sleep with the exact same untreated partner, they just catch the exact same pathogen all over again.
This is known in public health as the ping-pong effect. The infection just bounces back and forth between the partners indefinitely. To combat this broken chain, the text introduces a vital system-level workflow called expedited partner treatment, or EPT.
And how does that work?
EPT is a clinical practice where the provider gives the diagnosed patient a secondary prescription, or the actual physical medications, to take directly home to their sexual partner, without the provider ever seeing, examining, or establishing a medical record for that partner.
It feels counterintuitive to everything we are taught about prescribing only to established patients, but the public health imperative overrides it. It is explicitly designed to break the chain of transmission rapidly, and it is legally permissible in the vast majority of states, specifically for this reason.
It's a pragmatic, evidence-based solution to a systemic problem.
All right, we're rounding the final corner. We are concluding with obstructive uropathies and GU tumors. And this chapter truly brings everything we have discussed full circle. Chronic bacterial infections, jagged kidney stones, a massive hyperplastic prostate. These are all fundamentally forms of obstructive uropathy. And if they aren't relieved, the upstream hydrostatic pressure will ultimately destroy the renal architecture.
Box 136.1 categorizes these obstructions logically into intrinsic and extrinsic causes. Intrinsic obstructions are blockages originating from inside the plumbing itself.
So like stones.
Right, this could be intraluminal, like a free-floating kidney stone or a massive blood clot plugging the ureter. Or it could be structural, involving the wall of the tube itself, like a urethral stricture, where dense scar tissue from a prior infection narrows the lumen, or a malignant tumor growing directly out of the bladder lining.
Extrinsic obstructions are pathological processes originating completely outside the GU tract that grow large enough to compress the pliable ureters or urethra from the outside in.
BPH is the classic extrinsic example, where the prostate squeezes the urethra. But you also have to look systemically. A massive ovarian cyst, advanced cervical cancer, or even a severely expanding abdominal aortic aneurysm can physically impinge upon the ureters against the posterior abdominal wall, causing a silent, deadly backup of urine.
And the complications of leaving an obstruction untreated, as outlined in box 136.2.
They are biologically devastating. The primary complication is azotemia, the rapid, toxic buildup of nitrogenous waste products like urea and creatinine in the blood because the kidneys cannot filter against the back pressure. If prolonged, the high pressure literally crushes the nephrons, causing irreversible chronic renal failure.
Which we discussed earlier.
And, as we discussed with the obstructing stone, the stagnant urine becomes a breeding ground, leading to life-threatening urosepsis.
So the obstruction must be relieved. And sometimes, unfortunately, that intrinsic obstruction is a malignancy. Let's talk about the tumor workup. The text covers renal cell carcinoma, or RCC, Wilms tumor, and bladder cancer.
If you suspect a tumor, say, a patient presents with that classic painless macroscopic hematuria, or a dull, continuous flank pain without a history of stones. The diagnostic imaging of choice is a contrast-enhanced CT scan, or an MRI. You must visually define the mass, its invasion into surrounding tissues, and check the lymph nodes for metastasis. RCC, the most common kidney cancer in adults, is particularly dangerous.
Because it's resistant to chemo.
It is notoriously, historically resistant to traditional systemic chemotherapy and radiation.
Meaning you can't just shrink it with drugs. So what is the interprofessional play?
Aggressive, immediate surgical handoffs. Primary care must expedite the referral to a urologic oncologist. Because it resists chemo, surgical intervention, specifically a radical nephrectomy to completely remove the diseased kidney and surrounding fascia, or sometimes a nephron-sparing partial nephrectomy, is often the singular potential for a definitive cure in localized RCC.
What about Wilms tumor?
Wilms tumor, a highly aggressive kidney cancer seen primarily in young children, requires an immediate, coordinated pediatric oncology and surgical team. And bladder cancer mandates direct visualization and biopsy via cystoscopy by urology, followed by transurethral resection or intravesical immunotherapies.
The primary care provider is the crucial first link in this chain. Their role is maintaining a high index of suspicion, executing the rapid initial diagnostic imaging, and facilitating the seamless coordination of that massive specialty team.
Wow. We have traversed a massive amount of clinical ground today. If we are synthesizing this deep dive, the overarching, undeniable theme jumping out of this textbook is that the genitourinary system is intricately, inescapably interconnected with the rest of the body. It's never just a localized plumbing issue.
A symptom like painless microscopic hematuria on a routine physical, or a quiet complaint of erectile dysfunction that's a loose thread. And when you, the primary care clinician, decide to pull on that thread, it can unravel a massive systemic mystery, revealing everything from severe underlying cardiovascular atherosclerosis to silent growing malignancies.
And managing that interconnectedness demands a collaborative mindset. You cannot effectively manage the complexities of these patients alone in your clinic.
I want to leave you, our student listener, with a final provocative thought to ponder as you close your books today. As the landscape of primary care continues to rapidly evolve, the hard historical lines between specialties between urology, nephrology, cardiology, physical therapy, and primary care are blurring. The most successful, impactful clinicians of the future won't necessarily be the ones who have memorized every single obscure surgical technique or the exact molecular weight of every antibiotic.
The most successful clinicians will be the ones who master the nuance and the timing of their collaborative referrals. The ones who know exactly when a 5-millimeter stone requires a prescription for tamsulosin and exactly when a fever dictates an emergent call to the urologist for a stent. The ones who understand the depth of interprofessional communication required to keep a diabetic patient out of that terrifying red zone on the CKD heat map.
It is about knowing the limits of your own scope, recognizing the systemic red flags instantly, and trusting your interprofessional team to step in when the physiological complexity demands it. You have just mastered a dense, highly complex, and incredibly vital section of clinical knowledge. When you walk into the clinic and see your next patient suffering from incontinence, or agonizing over a kidney stone, or showing an elevated creatinine on their lab work, you aren't just going to see an isolated symptom. You're going to see the whole system at work. Keep studying, keep asking the why behind the what, and keep leaning on your collaborative team. We're wrapping it up here. A warm thank you from the Last Minute Lecture team.